She is the lead or directs the co-principal investigator of the federally funded PCORI Grant Community Engagement for Early Recognition and Immediate Action in Stroke Study, which is a multi-institutional academic community partnered program to address disparities in stroke awareness, barriers to healthcare access, and treatments and outcomes in Chicago's minority communities. Our second presenter, I'm hopefully not gonna mangle her name, is Ms. Jaskowitz. I did well. Okay, I'm proud of me. Ms. Jaskowitz is representing the Emory University's Cardiovascular Center for Women. And the two of them are going to talk to us about this particular disease and medical things that are particularly important to women. And after this, we'll have another question and answer and a break. So, Dr. Aggarwal?
Everyone ready? Get your seatbelts on, because I'm going to go at a faster clip, and I'm figuring out how to direct this. And just remember, my brain is thinking faster than this thing, okay? All right. First of all, big thank you for having me come here today. I've known Dr. Parker for many years, and I'm thrilled to be here, thrilled to talk about what's happening. And actually, you know, as I was listening to the previous speakers, I'm going to go through slides that have already been discussed. But again, it's all about memory, and I'm a neurologist, and I don't care how you get the information in. Sometimes you need to see it multiple times, and it's all good, okay? It's just exercising your brain and listening to what I'm going to say, and then at the end we'll have questions to really hone in on some things. I have to give gratitude. First off, I always start my programs with gratitude. Gratitude to all the people I work with at Rush, all my colleagues around the country, because a lot of the information I'm going to present today has really been gleaned by my training and also by listening to other colleagues think about how they feel about memory, cognition, and importantly, people in the field. I work in the field a lot. I'm in homes of people's houses in Chicago. We've done multiple studies where I'm actually on the streets in the homes. So I have a lot of different perspectives when you talk about memory. Quick thing about learning objectives. These are the objectives I want you to get from my presentation today, and really think about how this means something to you. Does it make sense to you? That is really where we need to start when we talk about cognitive aging, brain health, and especially when it comes to women. Now, one of the things that you've seen before, the slides about aging and how people are aging rapidly, I want you to take a look at this slide, because what it's visually showing you is that our population in the US is becoming a silo. What does that mean? It means that the top part of our population, the 65, 75, 85 and older age group, is now widening. So we don't have the point that was happening in the 1950s, and our base is pretty well staying the same. It has tremendous implications when you talk about economics. It has tremendous implications when you talk about brain aging, because now you're going to see people who are living longer, and now we as doctors are rethinking what is healthy aging, because we have more people living at extremely older ages. I was in the airport yesterday in Chicago. My flight was delayed as usual, coming from O'Hare. And what was on television? It was CNN with Sanjay Gupta, and he was talking to people who've made it to the age of 100. How do they live to be 100? And where are the blue zones, if you will, of where people are living to be 100? And it was fascinating because this talk was coming on in the airport in busy O'Hare, and I can tell you where I was sitting, people were watching and people were listening to that report, because they all want to know, how do you live longer? What is it to keep you healthy? And how does you keep your brain aging well? One thing I can tell you from that, a lot of the information I knew, but what he said was keep moving. You got to move. You got to move. That's when Mr. Lewis is, what he's doing is so important. I don't care where you are. You're in a chair, you're standing, you need to move. And that's what we're seeing in those blue zones. So, as people are living older, a couple things to think about. You have normal cognition, and then you have dementia. In between is the area that I call the gap. It is called the gap, and it's called mild cognitive impairment. And that's the zone, if you will, where people are kind of floating in and out of. They're having a little trouble with memory, but shoot, they're not as bad as their neighbor next door. All right? You know what I'm saying. All right, so they're in that zone, and here's my thing. Many people are in the zone. We need to keep you in the zone. We need to make sure you don't go into a dementia pattern, and that's what we call successful aging. So you heard a little bit about dementia, the terms we use. I call it the big D word because it's the word that nobody wants to hear, but it's really trouble with thinking and how you're functioning, and it should be going on more than 6 months. It shouldn't be less than 6 months because something else could happen that could cause that. But one thing I want you to know, this is not a US thing, dementia. It is a global issue. It's huge. It is a global issue. So if you have your people from other countries and where you're from, you may say, well, I hear about it now in my own native country. The biggest area that's going to be hit with dementia is going to be Asia, China, Japan, the whole Asia-Pacific rim, because the population is very, very high there, and the people are now living longer, something that they have never had to deal with before. It's a huge issue over in Asia. The other thing you've already seen, it is affecting basically people over the age of 85, 1 in 2 most likely has a dementia. Here's the thing though, the newest thing that's kind of hit the seed is women. Women are more risk of developing dementia, and frankly, we caregive for dementia. So we're getting a double hit. Now, Alzheimer's disease in general, here's one thing I want you to think about, that the length of Alzheimer's disease, people say all the time, Dr. A, how long can this go on? It can go on for 3 to 20 years. It's a long kind of a lifespan. So here it is. Dr. Parker made the comment, it's a chronic condition. We need to start thinking about it as a chronic condition, okay? And you have hypertension, diabetes, high cholesterol. Those are all chronic issues. We treat it, but it's chronic. This is the same thing happening here because the lifespan can go on for a long time. And that is something that we're really focusing on. How are we going to handle this? The issue with women, though, that when I look at this is that I'm seeing more women are having Alzheimer's disease, but take a look at this slide. It's going across all age groups. So it's not saying, oh, if you're 85 and older, you're going to have more women having it. No, you're going to also be having it more at 65. The rates are getting higher and higher because women are living longer. And that's an issue we got to deal with, and we got to figure out how are we going to manage this with women. And I'm going to go into that in a sec. You saw the differences between normal aging and Alzheimer's disease. Alzheimer's Association has a table outside. It has information there for you to read. Here's how I look at it when people say to me, should I be worried? Here's my question. Is this interfering with how you do the things you do? Is it interfering with your life? And if people say, yeah, it is, Dr. A, I'm missing bills. I'm not paying a mortgage. My utilities got cut off. Guess what? We got an issue. By the way, I don't say the word problem. There ain't no problem. It's issues. We are dealing with issues, okay? And we got an issue. All right. So, some things that are new on the scene that you may not know of is the sex and gender differences that are coming through right now with dementia and Alzheimer's disease. It is so important that we start talking about it. We need to talk about it. We need to look at it in our research because we're seeing differences between men and women. A friend of mine, she is a cardiologist, and she always says, you know, women are not little men. Got it? Women are not little men. So we got different things going on. So a couple things going on with sex differences. Women have a little bit, when you talk about cognitive and cognitive functioning, women have delayed recall of verbal memory. They also have trouble sometimes coming up with names more than men of items and things. And then the last thing is women and depression. Women are suffering from depression at a clip 2 to 1 more than men. It's real, it's there, and we need to address these issues about what are the differences between women and men because the treatments may be different. Now I'm going to switch gears for a second, and I'm going to talk about a topic that's coming up right now. It's called gender equity and disparities, et cetera, and what's going on here. And you're going to say, how does that fit with Alzheimer's disease? Well, let's talk about it in terms of women. Here it is with women, and this is how I think about things. When you're looking at women, women live longer than men, but remember one thing, that means we're not in also the workforce as long as men. Keep that in mind. We are entering the workforce later than men. Traditionally, and even now, we're in the workforce, but we're pulling out. What happens here then is then you go into a situation where you're not building up enough benefits. You're not building up enough, what I say, you know, capital, dollars, okay? And when that happens, then you get in a situation where, well, if I'm going to do this and I'm going to work, I'm not going to build up capital. At the time when I'm older and when I retire, I'm in poverty, and we're seeing it. Women are in poverty, and it's shocking when you look at the data. It's shocking how many women live in poverty. And basically what happens is that they become socially excluded from what's going on. So the longer lifespan is good, but it's also putting us at risk for poverty. What else it's doing is it's putting at risk for us for chronic medical conditions that we got to live with. So we are living longer with chronic conditions that are going on, and you can see here the common diseases and stresses of older people are really affecting women. And during that time, we start caregiving. We start to give care. It is the great equalizer. I say this all the time, and I heard it at a lecture, and she's right. Anne-Marie Slaughter was up in Chicago, and she made this comment. Care is the great equalizer for women, meaning that's what all of us are going to do. Doesn't matter socioeconomic, doesn't matter race, ethnicity, doesn't matter how much you earn. Care is going to be what's going to be asked of you as a woman to do, so it equalizes things. And what happens is when now you're dealing with medical conditions, and now let's say you're widowed because you've outlived your husband, here's the rule, and here's what we see. Widowed women don't remarry. Men remarry. Okay. So here it is. Now you have this going on, and you can see how this little slide keeps moving along. It's just one big arrow after an arrow. The bottom line on all this stuff is going to be this. Minorities are going to experience a double hit. Women and minority, we're going to have a double hit. This is an economic slide. I want you to keep this in your mind, how this all fits in, because it really relates to your health. Your health, your ability to work, and your ability to keep yourself as healthy so you can care for other people. Now, the other piece about dementia, Dr. Parker mentioned this, and basically there are different types of dementia. The reason why you hear about Alzheimer's, it's the most common, okay? And Alzheimer's, by the way, dementia is a rule-out diagnosis. I'm not ruling it in, I'm trying to rule it out. That's how I think as a neurologist. And these are all the different things I think about: history, blood tests, etc. That's what we work on. Dr. Parker can do this in her office when she's seeing people. She's doing the same thing. She's trying to rule it out, trying to fix something that she can fix before we start to talk about dementia. The problem is, though, even if we say dementia, that arrow is telling you it's not being diagnosed. Nobody's calling it, and that's my issue in Chicago. I see so many people coming in, hear about so many people having memory trouble. Doctor didn't call it. Doctor didn't say it. Doctor didn't say dementia. And doctor sure as heck didn't say Alzheimer's disease, but doctor didn't say dementia. So my messaging always is, if your issues that you have with memory and you're concerned, you have to ask, what is this? Why do you think it is? And what is going on? Call it. You want to call it. And we're not calling it enough. I have to show a picture of Dr. Alzheimer's because people ask me all the time, how did we get a name like Alzheimer? Who was this guy? Well, he's a psychiatrist. He was a German psychiatrist, and this was his patient, Augusta D. And look at the age that she presented with issues of memory. 51 years old. Memory, psychiatric issues. She was in a mental hospital in Germany because she was a psychiatric case. But basically, it's from this patient that he studied. He looked at the brain, and that's when you saw the plaques and tangles. That came from her brain. Okay, those were the things that he saw, and that's what stayed. So Alzheimer's disease, that's where it comes from, Dr. Alzheimer's. Now, 4 medicines for memory right now for dementia. They're on the FDA. The FDA has approved these 4 medicines. Here's the take home on all of them, in my opinion. None of them works better than the other, okay? It really depends. It depends on the doctor and how well the doctor is comfortable with the medicine and the side effect profile. It's an important point. Some doctors are very comfortable with using a patch. Some doctors are not, and this is the issue. There is really no one medicine that you're going to say, Dr. A, I want that medicine because it's better than the other. It's not, okay? Now, let's take a look at this. This is this issue about when is this whole business starting in the brain where you're starting to have issues with thinking. Well, guess what? It's already starting when you're happening around 40 years old, 50. Things are happening in your brain already. The plaques, the tangles, all those things are going on. The other things that are happening in your body are occurring. How you're living, your lifestyle is affecting a lot of these issues. So by the time you're showing up to the doctor's office, already I'm thinking, we already have this happening in the brain. So we're kind of behind the 8 ball. So the idea here is we got to treat earlier. And we got to learn to talk about Alzheimer's disease, dementia as a preventative thing. Preventing it should be in our dialogue. We need to prevent this disease. What can we do to prevent? Knowing that it's starting earlier already. This is where the lifestyle, the diet, the stress reduction comes in. And finally, in my community, in our research community, we're starting to think about it differently, okay? And we're starting to look at different imaging factors and different blood and spinal fluid to help us gauge when is this starting and what can we do to treat it. So we're not waiting to say, oh shoot, here it is, now what are we going to do? We get very busy near the end, and I keep saying you need to move it forward and go prevention, and get busy in prevention, okay? Why are you waiting until something's going on? This is my biggest thing in our minority communities, African American, Latino, and I'm going to say Asian too, my community. We just sit and wait. Sit and wait, and we pray upon it, we pray a little more, and we sit and wait. Can't do it. Can't do it. You gotta move. You gotta move on this. Okay. Here are the risk factors. Age, number one risk factor, women. Genetics, diabetes, cerebrovascular disease, depression. These are some of the risk factors now for developing Alzheimer's dementia. Protective, physical activity, apolipoprotein, I'll talk about in a second, years of education, social activities. The stars on that, besides some of those risk factors, indicate more prevalent and more different acting in women. See that? So all these things are now different acting in women. Very important thing to think about. The other thing that's different with women, let's take a look at some of this. Head injury. Concussion may be higher in women, leading to increased head injuries and Alzheimer's. We're seeing concussion rates very high in women, and frankly, the outcomes aren't good. The outcomes are different in women compared to men. When they're in sports concussion, whether they, frankly, spousal abuse, we don't even talk about that, causing head injury, okay? But these are some of the data coming through. The other things that are happening with women is that vitamin deficiencies, et cetera. We're not having that more social isolation with women, so therefore those things seem to be a risk. The other area that I always am looking at is homocysteine levels elevated in women with Alzheimer's disease. This is the risk factor, for, if you will, for strokes, the risk factor for vascular disease. And then the last thing here, lower income, lower occupational status, stronger effect in women. It affects women more than men. Okay? So these are some things right now to think about. Hormone therapy, of course, we have to talk about hormones. We have to talk about estrogen. But here again, it was thought that estrogen, if you had estrogen, you were thinking well. I hear it from my people. If the estrogen goes down, you're in the perimenopausal state. I'm not thinking right. I just don't think right. I'm fuzzy in the brain. We're seeing that imbalance of hormones causing issues for us. One of the things, though, is the heart-brain connection. And the heart-brain connection is becoming much more relevant now because when we look at what are risk factors in the U.S. and around the world that are really hurting people, it's heart disease. And it still remains as heart disease. So I want to show you this slide. The blue line is male, the red line is females, and basically you're looking at cardiovascular disease mortality, so the death trends. And the trends are going from 1979 to 2013. So you've got the death trends are high in men, and the death trends for heart disease were high in women. They were climbing too, but here's the thing. We didn't really know what was going on, and so then we started to use statins, and this is what the cardiologists, my cardiology colleagues were doing. Started to use statins. After using statins, you start to see the rates go down. They all start to go down a little bit in women too, and then we start to get into that very large study, the Women's Health Study. Remember, you heard about that. Okay, so then what's going on here? We started to know the Women's Health Initiative was started. We start to see now the heart disease rates go back up. What's going on? The men's heart disease go down and they start to leveling off. And then we realized hormone replacement therapy was stopped. Whoa, okay. So hormone replacement therapy wasn't such a great thing, right? Okay, and then after that, the awareness campaigns for women and heart disease started to occur, and finally, from awareness campaigns for women and heart disease, we started to see the rates go down. Heart disease still is killing women, but I want you to be aware of this. This is what happens when you start taking research and you start applying it, the research into the clinic populations, and now you see what's happening in our heart disease rates. The issue between heart disease and brain is that we are seeing heart disease risk factors really impacting brain functioning on multiple levels. I was so pleased to see the studies outside that are being done here at Emory that have to do with high blood pressure, looking at your heart risk factors and how it's affecting cognition. Because here it is, if you can control those risk factors, you can control how well you're thinking. To me, as a neurologist, where many of our conditions are chronic and disabling, that is very exciting to hear that. So I really am pleased to see these studies, and please take a look at those studies out there at the table. The Sirius study in Chicago is a stroke study that I wrote with a colleague, a stroke neurologist who's at Northwestern, and frankly, here it is in Chicago. Not only are we seeing dementia rates high, but we're seeing stroke rates high. Any of you familiar with Chicago? We have south side of Chicago, west side. Those are the areas that I work in Chicago in the field. And one thing I want you to be aware of, you see the dark browns over here, and then you see the dark blues. I want you to focus on that. Okay, the dark brown area is the number of stroke admissions coming into the hospitals, predominantly on the south side of Chicago. Dark brown means lots of stroke admissions. The dark blue sections and the lighter blue are showing you how many people basically are dying from it. So here it is. I'm out there in the field, and I keep saying, if I'm seeing a lot of something coming in a hospital with a lot of stroke and a lot of people coming through, and I'm seeing a death rate that's high, we got a problem. We have an issue, right? We have an issue. So how are we handling that? We are now educating people about their heart health. Keep your heart healthy so you don't have a stroke, but also keep your heart healthy so you don't have dementia. Guess what I see in my people in Chicago? We're having dementia and stroke go hand in hand. It's there. And we have Alzheimer's thrown in there. We don't just have these nice little buckets of things. We have a lot of things going on. So that is the area where we're focusing our prevention right now. Stroke prevention, heart disease prevention can lead to possibly dementia prevention and Alzheimer's dementia. That is how you have to think about it. You have to make those links. It is so important to make those links because when you do one thing, you can see how it affects another. A couple things I want to talk to you about. What is it with the heart? The heart basically, if you take a look at this slide, it's blood flow. How much blood flow is going to your brain? You got a healthy heart, you have more blood flow going to the brain. You have more blood flow going to the brain, you're going to think better. That's why exercise is so great. You feel good. Didn't you feel good after Mr. Lewis was up here? Come on. Mr. Lewis got the blood going, and you know what? He can do it while you're in a chair. So I think this is great. You don't need to stand up and do any of this. He can do it while you're in a chair. One of the things you need to realize, though, is that if you don't have that flow and if you don't have that activity, you're not getting enough blood to the brain isn't functioning the way it should. The other thing that's going on in the brain right now that we're learning about is that somehow the sugar that you need, the glucose in the brain that you need for your brain to work is not working. It's not being taken up the way it should, and we don't know why. And we think maybe the insulin uptake, the receptors there are not working the way they should. So there's a study going on right now. It's a sniff study. I don't know if we're doing it here at Emory, Monica. The sniff study is looking at nasal insulin given in the nose to people who have already mild memory issues to see if we can light up the brain. Take a look at these pictures. Placebo, you've got no nasal insulin being given. 20 units of nasal insulin, see the red area? That means those are new areas of the brain that are being activated, which means sugar is being taken in and utilized the way it should. And look at 40 units. That is a very interesting thing. When you see glucose utilization, enhancing that utilization is increasing your brain capacity and functioning. This nasal insulin study right now we're doing at Rush, and I'll be recruiting from the Heart Center for Women about that. Statins, well, that's another thing. What about statins, statin therapy? Does it affect cognitive functioning? This is an amazing area to really look at the research. There is so much research out on this. The epidemiology research does not fit the clinical, and when I'm in my clinic over in cardiology, and I have a clinic there I'll tell you about in a minute, people are saying all the time, Dr. A, I got put on statins, I'm not thinking right. I don't think right. And yet we're still trying to figure out what's going on. Right now, we looked at the literature, and basically there are no consistent studies either way to say statins are very beneficial or not beneficial for cognitive functioning. Doesn't mean we're not going to keep looking at it, but it's a hard thing to look at because epidemiology studies that are done in the communities, large community numbers are not jiving, if you will, with the clinic populations, okay? So the other thing that comes through is ApoE. ApoE is a genetic risk factor for developing Alzheimer's disease. There is a cardiology and a neurologic interaction here with ApoE. And the slide is just showing you from a cardiology perspective, basically we know when we do ApoE that there's going to be aberrant brain activity, tangle formation, aggregation, brain atrophy with ApoE. From the other area, it's loss of functioning, vascular functioning is decreasing, lipid and cholesterol metabolism is decreasing with ApoE. So you see how this is working together? ApoE, you think about Alzheimer's disease, but really there are some cardiology effects. There are some heart effects with ApoE. So we need to start thinking about it more in terms of how do we link those two together, heart function, brain function, even in the genetic area. Big question, Dr. A, I got Alzheimer's in my family, am I going to get it? Guess what? Most cases are sporadic. There are very few cases that are running family from generation to generation to generation, and they're coming around 10% of the cases. The other 90% are sporadic, okay? This is something that people don't realize. They think that for sure you're going to get this disease if you have a certain combination. What we do know, though, is people who live to be 100 have a certain genetic combination. This is interesting. The people who live to be 100 right now are more likely to have an ApoE2 combination in their genes. So we know there's something going on with the genes, and the 100-year-olds seem to be having a certain genetic component. But as what Sanjay Gupta said yesterday on CNN, it's a lifestyle. It's a lifestyle that can also make you live to very old ages too, not necessarily only genes. Family history. African American and white families were looked at in this slide, and I just wanted to raise this so you can see this. For an African American families, female relatives, male relatives, there's an increased risk of developing Alzheimer's disease if it's in the family and if there was a female or a male relative compared to white. The increased risk. But here's the word, and this is the big word. It's a risk. It doesn't mean for sure you're going to get this. So this idea, it's my destiny, this is what's going to happen, we've got to stop talking like that. Okay? And this is not just something in the African American community. In my Asian community, we talk about destiny, we talk about karma, we talk about these things, but what's happening is it's really affecting your health. It's affecting you being proactive on certain things that you can control. I always say this to my people, don't tell me what you can't do, tell me what you can do. That's what I'm interested in. I want to know what you can do. And that's something that is so, so important. Okay. So all this was going on. I'm in the field. I'm in our Alzheimer's Center, et cetera. And I finally said to Dr. Volkman, who is my mentor, she's the medical director of the Heart Center for Women, I said, you know what? I'm seeing your patients trying to come over to see me. She's worried about memory. She's seeing them in cardiology. They aren't coming. They're not coming to my Alzheimer's clinic. They don't want to come. I get it. No offense. I'm okay with it. I told Annabelle, I'm going to your clinic. I'm going to sit in your clinic. And that's what I did. I'm sitting in her clinic. I'm sitting in cardiology. And when she has patients tell her in the exam room, Dr. Volkman, I don't think I'm thinking right or I'm forgetful. You know what she says? You're going to go see Dr. Aggarwal and we're going to figure this out. Is it a medication thing? What else is going on? So we started the cardiology clinic at Rush. We've started this clinic. I started to do my memory screens in the clinic. The women are very receptive to this. They want to know what's going on. And basically what we found out with the women that we initially presented this to is that there's a lot of anxiety, there's a lot of concern, there's a lot of issues related to heart disease, panic about, am I going to have another heart attack? Am I going to die? Is that causing my memory issues coming through? So a lot of behavioral issues going through. The other thing that was very surprising for me was that there's a lot of family history of Alzheimer's disease in that cardiology clinic where people are talking about it. So here's my messaging to all the physicians out there. If you're a specialist and your people talk to you about something, pay attention and refer. They are going to tell you sometimes in a specialist kind of relationship. They may not go to primary care and say it, but they'll tell in a specialist relationship, you got to pay attention and refer, okay? So we also did a couple things in cardiology. The women said to me, Dr. A, can we start doing more of that electronic stuff, you know, all those luminosity things? Can we bring it to the clinic? I'm like, why not? Let's go to it. So we did a BrainFX tablet where we were doing memory tests. You know what we found out on that BrainFX tablet with the memory tests? Again, anxiety, depression, high on a lot of our women. So what does it tell me? Here's what it tells me. We need to address those issues and address them with data to say that we're taking care of it. Maybe that's the reason for the memory concerns. Maybe that's the reason what's going on with memory. It may not be dementia, and it may not be Alzheimer's. All right. So, yeah, even I have one of these moments every now and then. Here's a brain for Alzheimer's disease brain. I want you to see what the brains look like because at Rush we do a lot of brain autopsies. We're a fantastic center for doing autopsies. We have fantastic researchers. Doctors Bennett and Schneider really have developed this area of brain autopsies. And one of the things that you saw earlier is the plaques and tangles. We're able to look at plaques and tangles under the microscope. Those are the two hallmarks of Alzheimer's disease right now. The biggest thing right now that I can tell you, though, is looking at the plaque when you're living. This is wonderful when you're dead. People say to me, Dr. A, don't take my brain. I still need it. I said, I'm not taking it now. This is when you pass we want to have your brain. I know you need it. I need to see you with the brain in your head, right? All right. Here's the thing, though. The neuroimaging has moved our field so rapidly that it is just, I love it, because it's moving, moving, moving. And what's moving is the neuroimaging that's come through. This is a picture right here. You saw a little bit in the earlier presenter about the slide about the A4 study. See that red area? That's already the plaque going on in the brain. The drugs that we're developing are trying to make it look like that. Get rid of the red. That's what we want. That's what we want. And we're thinking if we can get rid of the red, guess what? You're going to think better. This is where the movement is going. Now, in the meantime, though, what do we got to do? Well, the first thing is, and I'm big on this, you got to keep calm. No drama. No drama, okay? Because here, from a neurologic perspective, when you get yourself worked up and when you stress yourself out, you don't think good. Okay? You know it, but I'm telling you there is a biological mechanism going on here, cortisol. Cortisol is increased. It's affecting your hippocampal cells. I can go through this whole mechanism for you, but you know what you know, and you know you need to stay calm. So you need to keep calm. You need to eat a healthier diet. We all know that. You heard about the diet, the Mediterranean diet earlier. Well, guess what? We're going to be starting a new study in Chicago and in Boston called the Mind Diet, where we're looking at giving people who are not exercising, who don't eat right, we're going to find them in Chicago, we're going to find them in Boston, and we're going to start giving them nuts and berries and blueberries, and we're going to give this to them, and they've got to put it in their diet, and we're going to follow you for a couple years and see how your thinking is. Very exciting. The other thing is get moving. Thank goodness, again, that we had Mr. Lewis up here. I can't say it enough. You got to move. Here it is. Exercise, I love it. You want to go to the club, you go to the club. You want to go ahead and do water aerobics, you do it. But you know what? Can you just walk? And if you can't walk, do what he's doing. It counts. It all counts. And that's what I tell my people. It all counts. None of this, it don't count. It counts. Move, move, move. The other thing, again, Sanjay Gupta's CNN event over there at O'Hare, you know what it said? They're talking about all the people living to 100. How are they living to 100? About exercise. He made this comment. You know, they said, there's no exercise. It's just part of life. We move. We are built to move. Dr. Tamara is going to come up here. She's orthopedic. She's going to tell you all about bones and joints and everything. We got joints to make us move. You got to move, okay? Other thing, reduce stress. How do you do that? Simple, simple. Anything that works for you works for me. As long as it's not hurting anyone, it doesn't hurt your body. What does that mean? If you have to go fishing, you go fishing. If you like to knit, you knit. That is a stress reduction, and you have to start paying attention what really makes you feel good about reducing stress. The idea by reducing stress is this. You reduce your stress, your blood pressure is going to go down, your sugars are going to go down, your fatigue, your aches, a lot of those things can go down by reducing stress. And guess what? Your memory goes up, all right? And then here's the one, my favorite one. This is my 102-year-old patient told me. I asked him, how did he make it to 102? Okay, this is outside of Chicago. Just keep in mind, I'm in the house the day after. Gangbangers were basically shut down at the end of the street. The cops were there. They were taping off the house. Okay, got a picture of where this man is living? Here I am. I'm seeing him for one of our studies, and I asked him. Okay, finished the study, perfect memory, everything's going good, dressed in a suit, he's going off to Bible study. He's leading Bible study. God bless, right? So I said to him, before you go, I want to ask you, how'd you make it to 102? And he told me some really important things. He said, well, first of all, I didn't start off like this. I started to get my act together when I was 65. Just smiled when he said that. Because again, I'm thinking in my head, 102, 65, okay. He said to me a couple things. Every morning I get up, I got a purpose. I get up and I get ready. I don't lounge around. I don't wear no loungewear. I don't stay in my pajamas. I get ready. All right. Second thing, it says attitude of gratitude. That's what I got. Attitude of gratitude every day. Thank you, God, for getting me up. And when I go to bed, thank you, God, for this day. And hopefully I'll get up tomorrow morning. But thank you, thank you, thank you. Third thing he said to me, this is typical Southside Chicago. I got no time for stinking thinking. No time. I said, talk to me. What are you saying about that? Dr. A, I hang around people who lift me up and don't pull me down. Okay. Oh, powerful message there. I said, and so I'm talking to him. I go, well, what do you do about your family? I know what goes on. You know, he said to me, Dr. A, good question, he said to me. I cut him loose. He cut him loose after he remarried, and it was a very bad situation. And I asked him, can I tell the story? He goes, go ahead, spread it out. He goes, you're my voice, you need to push it out. Here's what he said. When he got remarried, the family treated the new wife very, very poorly. She was a widow herself. Her husband died of cancer. His wife died of cancer. They were coming together, same church. Okay, treated her very badly. So finally he said, she doesn't deserve this, had a family meeting, sat down and said, who's with me and who's not? That was it. And but you know how he started it? Because this is a tough discussion. You know what he said? You are my family, you are my people, I will always love you. But I need to know who's with me and who's not. That's how you start these discussions. You're my people, you're my blood, I get it. But will you? And that's what he said. He cut him loose. I said, who stayed? I'm going to the door now. I said, hey, I got to ask you a question. Who stayed? My grandkids, my great-grands, a daughter, 2 sons, but the rest of them all just, that was it. That is number one. You need to keep your social engagements going with people you like. All right. Got it? And I mean this, we laugh about it, but it is so true. Monica will tell you this in her office. She will see people who are thriving in the right environment. She will see people who are coming in who are not in the right environment and are going downhill. It hurts us as doctors when we see this and we don't know how to navigate through that because we know what's going on. I'm in the house. I see this go down. I am telling you, keep that in mind. Is this helping me or is it hurting me? And only you know what it's doing to you, but you keep that in mind, all right? Okay, so I'm going to end on this right now. I'm going to think about all that I've been saying, but the issue with women is even more important when it comes through here. Women, we tend not to eat healthier diets until later on, but initially we don't because we're feeding everybody else. Women, we don't really move at all. We don't move. We sit around a lot. And in different cultures, by the way, for cultural competency, different cultures want women sitting all the time. Sit down. And my deal is stand up. All right. Next thing, sleeping. We're not sleeping the way we should. Half of America doesn't sleep. The other half is up at 3 a.m. doing stupid stuff. Okay? The point is, I need you to sleep, and I need you to think about sleep, and here's why I'm going to talk to you about sleep. Do you know if you don't sleep, there is evidence right now in the research to suggest amyloid plaques are being dropped in your head and deposited more than people who do sleep? Ooh. If that isn't going to make you want to sleep and go ahead and really focus on sleep, then you better start thinking about sleep and take it seriously. Seriously about sleep, okay? Reduce your stress. How many times have you heard women say this? Oh, I'm a multitasker, Dr. A, and I just, wear it like a badge. I can do this and I can do this, and I'm always saying, are you stressed? You bet I'm stressed. Get rid of the stress and drop the multitasking. We think it's something that's so proud to be, don't do it. It is not an efficient way for your brain to work. The brain does multiple things at different times, but when you do too much, you are on overload. And guess what happens? Nothing gets done. And when nothing gets done, your stress goes up. So I'm going to tell you right now what I tell my people in Chicago, and knock it off with the multitasking. One thing at a time, complete it, move on to the next, but don't do all this multitasking. And then the last thing is the social. Be where you want to be with people you like. It is going to help you live longer and a healthier life. All right, that's it for me. Thank you.